Good morning. Today I'll be talking about caring for the urology patient in Uganda, and I'll be describing the healthcare system in Uganda, the training, and describing the urology service and provision of care in Uganda. Just a little bit about Uganda's history. It was a British protectorate from 1894 to 1962, initially visited by missionaries and explorers and lots of people looking for raw materials for the Industrial Revolution in Europe. And after that, to protect their resources, we made a protectorate and a member of the Commonwealth. And since then, we've been a member of the Commonwealth. In 1962, Uganda was granted its independence with its first president, Mutesa II. He was one of the kings of the local kingdoms that welcomed the British in the center of the country at that time. His prime minister was called Obote, and in 1963, through political maneuverings, the prime minister became president, abolished kingdoms, and he took all government powers and became the absolute leader, almost close to the Ayatollah. And so we've had lots of civil strife since 1971 when Idi Amin, who was the army general for Obote, during the president's state visit somewhere in Europe, he assumed all powers and controlled the country with the military. We had multiple coups and lots of short-term presidents, others lasting a week, a month, and most of them less than a year. Until 1986, when the current president, called Museveni, he assumed presidency in a coup. He was a rebel leader and came in with loads of armies with support from Tanzanian armies and took over the presidency then. When he took over presidency, we had a civil war as well in the north of the country, lasting for over 20 years. And probably some of you might have heard of the Lord's Resistance Army with the child soldiers and night commuters from 1986 until 2008. In Uganda, the activities of this rebel group have stopped, but they're in Central African Republic, are still killing lots of people, abducting children and women. In 2006, we had our first general elections, and the same president has been president since. We keep voting him in, whether we want to or not. More about Uganda. It was coined as the Pearl of Africa by Sir Winston Churchill, who was the Prime Minister of the British Empire in 1909. Our population is about 36 million. And it's quite similar to that of Canada, although the geographical area is that of Oregon. It's home to the source of the Nile and the second largest freshwater lake in the world after the Caspian Sea. We sit right on the equator, and we have 12 and 12 hours of light and darkness. Of course, more about that, we have lots of mountains, volcanic and block mountains, and one of our mountains has equatorial glaciers. We also have lots of wildlife in national parks, tropical forests, rivers and lakes, and it's also the home to the last king of Scotland pictured below. The geographical area, again, to emphasize it, is the size of Oregon, so you can imagine the population density. Uganda's GDP is about $1,500 US compared to about 52,000 in Canada. Our literacy rate is about 67%. Compared to 99% in Canada. Our life expectancy at birth is 58 years and 81 in Canada here. Our median age and most of our population is under the age of 15 years compared to persons 42 years here. We're actually the youngest country in the world with the biggest number of people below 15 years of age. In describing Uganda's healthcare, sort of funded both privately and by the government, but most of the population that's rural, over 70%, depends on government-funded facilities. So through the Ministry of Health, we have a national referral hospital, which is in the capital. It's called Mulago Hospital, and that's where I did my general surgery training. And hospitals feeding this are regional referral hospitals that are in over 8 regions. And we have what we call private not-for-profit hospitals that are NGO-based hospitals, whether it's faith-based or some embassy or country funds the hospital, and so they come into existence. We also have the private for-profit, where it's fee-for-service, and private clinics. So referring to the regional referral hospitals are what we call health center fours. They're district hospitals, and there's over 50 of those. And it's run by what we call a medical officer. The equivalent here, not really an equivalent, maybe it would be a GP without residency in family practice. That's what I would call them, because you do a year of internship, and then you would run one of these health centers. And below this are health center fours, and again, they can refer to anywhere if they think the care that they have available is not appropriate. How do we fund health in Uganda? So over 25% of Uganda's budget, national budget, is funded by foreign governments, the World Bank and such. In 2012, the funding went down to 25%, but it used to be 42% 2 years prior. All of this is really because of donor community not happy with some of the decision and conditionality of donor money. And only 2.5% of our GDP is allocated to health, and from the national budget, compared to 11.6 here in Canada. The public institutions are funded by the government through the Ministry of Finance or the Ministry of Health, and faith-based or NGO hospitals are funded by those organizations or the donors directly into the hospital. For example, the Italian embassy would fund a hospital that's run by Italian missionaries directly, or the Belgian embassy would maybe fund some programs within the Ministry of Health and such. In the fee-for-service hospitals, either some employees will have health insurance for their employees, and they can cover the family members except for congenital conditions. And then, of course, the rest would be paid directly by the patients. So what's the road to urology? When we finish our education system is 7 years of primary school, and then we do 6 years of secondary school. 4 years is ordinary levels, we call them O levels from a British system, and then A levels. After that, we go directly to university and have a 5-year medical school, and you graduate with a MBChB. We do a 1 year of a mandatory internship, in which you do a rotation in all the major 4 disciplines: obs-gyn, general surgery, internal medicine, and general pediatrics. And during that time, you're supervised by specialists, and you get a subjective assessment at the end of this. If you pass, then you can become what we call a medical officer. And following this, at least 1 to 2 years, you must work as a medical officer, because most of our medical school is funded by the government, and only about 20% fund themselves. So you have to sort of give a payback time of about 1 to 2 years service to a public hospital or a regional center. After doing this time, you can then apply for your residency, or what we call the MMed in surgery, that are offered by 2 universities in the country. It's a 3-year program in which you do general surgery, and you go through the major rotations in the different disciplines, whether it's neurosurgery or urology or trauma and the like. Parallel to this is the College of East, Central and Southern Africa, that also does train surgeons for the region and Uganda as well. It's a 5-year program, and the first part, after doing that part, you achieve what they call a member of the College of Surgeons of East, Central and Southern Africa, followed by a 3 core part that you would do an exam, and you'd get a fellowship exam. This program is clinical based, while the MMed is both clinical and research based, and you have to, before you graduate, you must have a research thesis written. And then, of course, after becoming a general surgeon, then you must do 2 years either as a fellowship or an MSc to become a urologist. We only have 5 such people that have met these requirements, and they're all stationed at the National Referral Hospital. The MSCs, most of them have been done either in India or in Tanzania, that's the country just south of Uganda, has one of the universities that offers an MSc in urology. Other groups that take part in training, in a different kind of model have been MMed, an Italian NGO called Surgery for Children, Bolzano Hospital in the northwest of Italy, University of British Columbia, like in the capacity I'm in here. Sort of, it's not that to train you as a whole urologist, but to impart some form of skill. And so most of these have been based in lecture forms, consultations, apprentice-style skills transfer, clinical placements, and electives abroad, again, just like myself. And so how do we provide care? So in the public institutions, so either through, we have 5 urologists in the National Referral Hospital, and only one of them has extra training as a pediatric urologist. The others have sort of either learned from groups that visit or learned from her. In the regional referral hospitals, the general surgeons offer urology care, and of course, again, it's limited to what the skill is and what the facilities are like in those hospitals. In the private hospitals, the same urologists, general surgeons, and all sorts of different people, including witch doctors, will give care, because you just never know, from a clinic to an established hospital, people are giving all sorts of care, particularly with circumcisions. Again, in the NGO hospitals, we'll have general surgeons or urologists from groups that are collaborating with the institution giving care. The other way is we do rural outreaches with the local surgical associations, where there is consultation, skills transfer, and support supervision of the local general surgeons. Again, we do some rural outreaches with groups that collaborate, including a team from UBC and Surgery for Children from Italy. Of course, there is the solitary one-time surgeons that come in for a short time and then go away. This is just some of the pictures showing lots of patients queued up waiting for consultations in one of the rural hospitals, and that's us working with a team that we collaborate with offering care. Just a few details about what the different groups do. With UBC, together with the Swedish in Seattle and Sick Kids in Toronto, they've had urologists come from these 2 places, and we've had 2 hernia camps. This was mostly to clear backlog and just sort of put a dent in numbers, whether it's hernias, ocupexies, and the rest. We've also had more complex camps or visits where there's complex and reconstructive pediatric urology and and general surgery, where again they're clearing backlog, doing consultations, and doing surgery. And the teams from Sick Kids and here have been involved in that. Again, MMed sponsors a traveling scholar, and so they come to Uganda giving lectures, do consultations, and do some or demonstrations of some skill. I've not been involved in any of these trainings, so I'm not sure about the details. Then there is the sporadic surgeons. They usually fly in unsupervised. They don't work with any of the local team. They do whatever they do and they leave. Most times we know about them when you start getting complications referred to you, that XYZ came to this institution and we went there, we were desperate, and then here we are. The other is Surgery for Children. The team comprises of general pediatric surgeons and pediatric urologists, and again, they've been coming to Uganda for over 10 years. They go to the northern part of the country, and they started going there during the time of war, when there's very little surgical support to that part of the country. And so they've continued going there even after the civil war has ended. Again, they help with clearing of backlog, and now more involved in skills transfer and service provision. Again, the province of Bolzano in Italy, together with the general hospital there, they've been able to fund the same missionary hospital in the north of the country. The province does fund for a general surgeon to have a training, clinical training in the hospital, in the urology unit in Bolzano, mostly in adult surgery, but they've had general adult urologists as well as pediatric urologists come to Uganda for months on end to help support and transfer skills to the local pediatric surgeon and the doctors working in the hospital. So what are the common conditions? We have large hydrocele, so whether they're secretory or they're from elephantiasis because of filariasis is one of the two. lots of urethral strictures from trauma and sexually transmitted infections, of course BPH and cancer of the prostate, HIV and associated conditions including HPV, condylomata, nasty stuff, cancer of the penis, and Fournier's gangrene. With the advent of HIV, we saw more cases of Fournier's gangrene because it's much more common in the immunocompromised, and so we saw lots of patients coming with this. Of course, pediatric urology, there is a huge load of cases, including intersex hypospadias, enuresis, stone disease, urethral valves, and Wilms tumor. Just in the unit in Mulago, where most of the, let's say, the general surgeons do the Wilms tumors, you could easily do one Wilms tumor, at least one or every 2 weeks in the year. That's how many there are. And of course, the other conditions include stone disease, obstruction, duplications, and reflux, and other renal tumors. And this just shows a large hydrocele. It's not elephantiasis, but it's quite large, coming to almost the mid-thigh. And they only come to hospital when there's some sexual dysfunction ensues from this. This is the typical hernia you will see in a Ugandan child, in the picture below that, and they're quite big. And again, a child with a cloacal extrophy. A lot of these die from whether it's sepsis, inability to feed. This child got a stoma, but we couldn't do much else with this child, and this passed on within days. Of course, the lowermost picture, we have to share our work with witch doctors and traditional healers. You can see the therapeutic marks on the child's abdomen. This child had a polycystic kidney, and of course, they first went to the witch doctor to have, I don't know what knots inserted in the skin. Most of them do die of sepsis from infections going into those cuts. Just how do we manage some of the common conditions? For example, BPH and cancer of the prostate. We first see the patients when they come in with obstructive symptoms, and then we work them up. So they either get a Foley catheter or suprapubic catheter, usually by the general surgeon or the general surgical team, either an ultrasound done for volume and bladder residuals, a true cut biopsy without image guidance, and so if it's just a BPH, they'll get an open prostatectomy, or in 2 of the centers, they can do a TURP if the tower is working. And then, of course, if it's cancer of the prostate from your true cut biopsy, they may have a radical prostatectomy if it's amenable, or depending on the skill of the surgeon. And if the patient can afford it, you will follow PSS, and most of them will do bilateral ochiectomies. And the cancers of the penis, which is quite common again because of HIV, they'll get either partial or total penectomy depending on what grade it is. Urethral strictures is another difficult group, very common because of sexually transmitted infections, but also TB and trauma. I've seen one case with TB urethra with multiple strictures, nasty looking urethral mucosa. A lot of these difficult to manage, and most of the surgeons will not attempt them. So most of them do depend on visiting teams when they do come for the surgeries to happen. Stone disease, of course, we're limited to open surgery for most bladder and renal stones. We'll not do any, if there's a tower, you might be able to do lithotomy, but will not have any lithotripsy, no ureteroscopy, and for some of the other conditions, of course, laparoscopy is a myth. In pediatric surgery, urethral valves. Now, this is another group that waits. So usually, if they've not died, you see them with obstruction. You would either insert a Foley catheter or construct a suprapubic or vesicostomy, and then they'll wait for a visiting surgeon that comes with a pediatric scope to do mass ablation of valves in a given visit. Hypospadias, 2 of the adult urologists do them. The one that has extra ped urology training, and one of the others that's got some skill from her. They do most of these surgeries in private institutions, and so the patients have to pay for this service. Majority of the patients that cannot pay will have to wait for outreaches, either by the local teams or when we have visiting teams that come with us. Of course, intersex, we are limited to doing a karyotyping from the mucosa and or laparotomy and maybe an ultrasound. It mostly falls, management of these patients, or at least assessment, falls to the visiting teams, although sometimes there's complications from ill-advised operations, like they'll come in with perineal hypospadias or something, and someone will just repair hypospadias without checking that is this a girl or is it a boy, what gonads are those, and then you end up with all sorts of complications. And at 13 years, she develops boobs. The other is schistosomiasis. Going through medical school, the first thing the pathologists would put on the board is the menstruating men of Egypt. So we had to know this. Uganda lies in the Nile basin, and we have lots of schistosomiasis around Lake Victoria and along the Nile. Schistosoma loves the water, and particularly will cause conditions in the GI tract and the urogenital tract. So particularly for this group, it will be hematuria, chronic cystitis with polyps, and it's been implicated in squamous cell carcinoma of the bladder. They may present with anything or chronic pain and bleeding. The other is TB, so it will cause anything, anywhere, and again, much more common in immunocompromised patients, whether it's HIV or they're malnourished, and will cause anything from the kidney down to the urethra. The other is filariasis, which is a hemoparasite transmitted by a mosquito bite. Typically will cause lymphangitis and also epididymitis and otitis. They'll present with either scrotal or penile elephantiasis. Very difficult to manage, and most times you require plastic surgeons for reconstruction. The patients with spina bifida. Many die from meningitis, usually resulting from rupture and sepsis of the membrane. Resulting hydrocephalus is managed by external VP shunts, except in one of the hospitals that's faith-based, where they'll have a third ventriculostomy. This is the institution where it was first developed, but that's the only place where it happens, and the patients have to pay for care. So almost all the others, they're either dead or they'll wait to have an external shunt if you can raise the money. Trauma is another thing. Pictured there are what we call border borders. They're taxi bikes, and we use them all the time in Uganda. They're the biggest cause of trauma and deaths from head injuries and spinal injuries. For both spina bifida or even patients with spinal trauma following road traffic accidents, we have no multidisciplinary or even usually anyone to care for these patients or follow up. What we always say is, if you don't see them, they're either well or they're dead. So, but in the past, in the north of the country where we had the war with lots of landmines and gunshot wounds, we had two NGOs that were taking part. One, AFSI, is an Italian NGO. It's out of the Vatican, and Terre des Hommes from France. What they did is they went into the communities, they identified people that were paraplegic or quadriplegic, brought them to hospitals. They were taught how to look after their pressure sores. They taught them intermittent catheterization and gave some supply to some of the hospitals to be able to equip these patients. After the war ended in 2008, that was the end of this. And female genital mutilation. One of the tribes in Uganda does do this, and it will involve excision of the clitoris without excision of the labia minora or majora, and sealing with only leaving an opening for voiding. It's quite common. In Uganda now, they've made a law where it's outlawed, so they're not doing it anymore. Or they still do it, but no one's saying. But where they had it as a huge cultural celebration, it's no longer happening because it's not allowed. Vesicovaginal fistula. We have lots of obstructed labor, usually following cephalopelvic disproportion. A lot of it's been attributed to stunting. In Uganda, the average prevalence of stunting in a five-year-old child is 45%, and the median age of the first pregnancy is 18 years of age compared to 29 years here. So a lot of mothers are very small, and probably their babies are too big to come out of their pelvis. So a lot of them will labor for long hours with a traditional birth attendant, and when it's lots of hours and lots of pressure necrosis has taken place, then they'll go to a medical facility. The surgery and reconstruction of this is done by local obs-gyn surgeons, and one of the urologists also does this together with AMREF, and they do outreaches throughout the country at different periods to help solve this problem. Antibiotic use. So here, when you treat a patient and maybe some drugs not working, you're thinking resistance. In Uganda, we're thinking it's not efficacious because probably there's 1% of the effective drug in there. Usually the drugs are approved by the National Drug Authority and procured by the national medical stores. And so again, most of the drugs are inefficacious, and most times if the patients don't get better, you probably prescribe the very same drug and tell them, go get a brand that's made in XYZ country instead of the other one, and usually the patients get better. So we all know that, but it's what we have to live with.
You mean those drugs are coming from Germany?
Not the bad ones. The ones you tell them to go buy instead when they're not getting better.
Where are the bad ones coming
from? From India and China. Yeah. And male circumcision. I don't know very much about this, as I've not been involved in a lot of this this drive. Urologists have been involved in the initial phases to help train people in doing circumcisions with devices and things like that, and they were involved in the initial research stages. WHO pays for the national drive for this, and there is huge numbers of centers where you just have a queue of like 200 people waiting outside a tent to have a circumcision every day. And all sorts of people are doing this, and this is one of the areas where from the witch doctor to the urologist, everyone's doing an operation. And following this, there's been lots of complications resulting from this, lots of urethroperitoneous fistulas, and that's the group that we usually would see in the pediatric unit or in the general hospitals, or if you're unlucky, you have your glands or part of your penis amputated from whatever happens. It is quick money, so if you're tired of the queue, anyone can do it quickly anywhere, and fee for service, like, oh, I can do it in I don't know how many minutes. For this amount of money, come to this dingy place and get the surgery done. Of course, proponents for this have said that it's help reduce female-to-male transmission of HIV, although it's very ineffective for the female-to-male transmission or for the insertee in HIV. It's also been a reduction seen for human papillomavirus for both male and female, although it's not known in same-sex relationships. Herpes simplex 2 as well is decreased from female to male transmission, but not for the others. One thing is people go around Uganda, and what this has done is people think they will not get HIV. So their behavior is in a way that you'll even get more partners, you'll have even less protection, because if I'm circumcised, I'm good. If my partner is circumcised, we are good. So that's what's going around, and probably there's going to be much more HIV rebounding from this because of no one's tackling the behavior, while whatever knowledge you give people, they will choose what they want to hear. Just to go back to some of the investigations we have, we're limited to an ultrasound, a plain x-ray. You'll get those for free in a public hospital. If you want a CT scan, you'll have to pay for it. If you want a contrast study, you will have to pay for it. And if you want to have a PSA to monitor anything, you would have to pay for that. Workplace injury. Again, we work in a country that has a prevalence of maybe 7% HIV, and there may be lots of workplace injuries, whether it's from handling patients from bloody trauma or in surgery. And every hospital or even smallest unit has HIV clinics, and they have physicians that will do the assessment and give you appropriate treatment if needed. And yes, thank you.